So there will be few overlapping slides. I'm going to quickly walk through. Many of my previous speakers are already spoken on that. So we all know, although the disease is the same, no two patients behave the same in their response to therapy. So we have to customize even at the molecular assay level. The previous speaker has also said the same thing. So every test, so when you said that informed and unnaive and all that, so there is a way of doing it. You can do it individually or you can take a broader panel because the cost of NGS has come down significantly. So WES may become the testing, whole exome sequencing, as we see reduction in cost. So tumor heterogeneity is an intrinsic thing which is present in every cancer, be it early stage, be it advanced stage. And this is just a pictorial representation to show intra-tumor heterogeneity and inter-tumor heterogeneity in among different individuals. So there is always a chance how the needle is entering while doing the biopsy. Are we taking up every possible clonal mutation which is driven by a specific, every possible tumor clone which is driven by a specific mutation or group of mutations. So nobody knows that, because if human beings had a microscopic eye to see a DNA mutation, we would have picked it up easily. Single cell is there, but I don't think it can reach clinic so easily. So this is cancer. So it has many ways of attacking, and it's no longer one gene, one drug. One has to look at multiple genes which are driving the disease in order to understand the disease in first place. And if you kill only one mutation clone, the rest are still active. In fact, they become much more aggressive. It becomes very difficult to handle. So in first place, at the baseline itself, if you understand all the clones in detail, you know how you are taking the disease forward. So this is what we understand today. So comprehensive understanding of the disease by looking at combined tissue and liquid. The reason why I said that is, as I said previously, tissue biopsy is a local sampling event, whereas liquid biopsy is a holistic sampling. So that in fact adds value in understanding the biology of the disease. That's the reason why we are able to understand the disease in a better way when you combine both tissue and liquid. So beyond all this, today in 2022, some of our senior teachers, Douglas Hanahan, this also is a previous speaker's repetition, but what I want to say here is, although we understand so many properties, where are drugs available today? These are the places where I have indicated stars where we have drugs today. So that means to say that each of these clones have some role to play in terms of combination therapy. Dr. Seventy previously mentioned, right, in exon 21, adding anti-angiogenic drug. You don't know the angiogenic marker is actually activated or not, but an indirect information is coming from the mutation that this tumor is driven by angiogenesis. So in that way, understanding all the properties, molecular properties of the cancer cell becomes very important in first place to start treating the patient in the best possible way. So this is one classical example. Suppose there is lung cancer and there are two different types of clones and you gave a drug A. It kills the clones which have the specific mutation, but the other clone remains silent. As you start killing that, the other one starts getting dominating because it starts getting more nurture. So you see response, but you won't get the best response with one drug unless you do the drug combination. Another scenario, okay, let's say we had a proper response, slowly shrink, then when it comes out as a secondary resistance or a mechanism of resistance, the new clone, then also you don't have a proper answer unless you treat them with combination of drugs. So where all this is going? Solution is, one has to look at both tissue and liquid at baseline at least to understand the comprehensive nature of the disease. So where all we need to do, we need not do throughout the journey of the patient. First, at the time of diagnosis, it becomes very important to know this. Subsequently, depending on the affordability of the patient and the doctor's call, if there is surgery or no surgery, it's going to be like metastatic presentation again at baseline is important. In early presentation, post-surgery, one can look at liquid biopsy to understand venereal residual disease. So what we did, I'm just giving you 2 case examples using a gene panel, Indigene. Done? I'm over. Oh my God. Sorry. So this is a classical case of ROS1 fusion. Example is the fusion was identified in tissue, but the mechanism of resistance could be picked up only in liquid. So this is a very clear example that you have to look at both tissue and liquid together. Another example, one second ma'am, just 1 second. This is a case of 2 drivers. First, the clinician killed the first driver with ROS1 target. Then after 1 year, we got the slow growing driver, L858R. I think this is this, and there was another, session that if you cannot do big panels, at least look at driver mutations as a screening panel in first go. I think I'll stop here. This is one important message. Molecular limit of detection, again going back to Dr. Sudha's session, clinical limit of detection using imaging is different from molecular limit of detection. That is where liquid biopsy helps along with tissue biopsy. Yeah, thank you. And where all it started? It started in lung 3 and 6 trials, where they said knowing ctDNA levels in plasma or liquid biopsy is a good prognostic biomarker. It tells that the patient is going to do very badly. Thank you for your attention.